Right, good evening and welcome to this evening's Med Chi. First of all, a few introductory things to remind you that there's a few things that are happening. There's a meal at Chung's restaurant, which is going to be on the 21st of November, and there are still places available. So if you'd like to come, it's a very nice evening, and we'd welcome you. I'd like you to have a look at the minutes of the last meeting, which are available outside and will be on the website. And that was the meeting which we held on the 10th of October, which was me talking about a terrace in Knightsbridge. So, with no more ado, I'd like to introduce our speaker tonight, who really just shouldn't need a great deal of introduction. Professor Steve Field chaired the NHS Future Forum, so I'm sure he'll say something about that. He's now Deputy Medical Director at the National Commissioning Board, being responsible for health inequalities. He's the immediate past Chair of the Royal College of General Practitioners, and is a GP in Birmingham to do a surgery tomorrow. So, Steve, I'd like to introduce you to come and talk to us tonight about health in some of the deprived communities.
Okay, thanks, Nigel. Great. Well, thanks for inviting me. How many of you are GPs before the lights disappear? And the rest of you are in hospitals? Any of you not medics? Good. Excellent. 3. Excellent. Right. So, thanks, Nigel. It's great to be here. I've never been in this theatre before. It looks pretty smart, actually, doesn't it? Probably even better when it's full, but there you go. So what I'd like to do is talk through some of the issues about health inclusion and give you some data about why it's a problem, and then talk about some of the solutions, and then spend probably the same amount of time sort of having a chat and asking and answering questions on anything, which might include where on earth we are with the NHS at the moment. I'm quite happy to talk about that. So my day job, I think, is to challenge and make sure that our commissioning board, which is the body which has 110 billion pounds worth of your taxpayers' money, starts to deliver on health inequalities, and working in partnership with Public Health England, with all the public health physicians in local government, with Health Education England, about getting the skills and the training of doctors and nurses and others up to scratch in order to have a good go at the health inequalities part from the medical point of view. But also to recognise that the social determinants of health, all of Michael Marmot's work, of course, pervade everything we're doing. So if we want to reduce health inequalities in England, people need to have jobs, they need to have a living wage, they need housing, and they need support. And so a lot of people would say that health inequalities are very difficult as a doctor to address because the social determinants swamp everything. And indeed, when I stood for the election for the chair of the College of GPs, my sort of election address was about the college leading on doing something on health inequalities. And then the current president stood up and questioned me and said, you're deluded. In fact, as doctors, we can't do very much about health inequalities because it's all about social determinants and the income in the country. Well, that's partly true. But if you look at the last 12 years in England, the inequality gap between the richest and the poorest has increased. For women, it's increased by 13.3%, and for men by 4%, which means that if you live in North Blackpool, your life expectancy is 20 years shorter than if you live in the centre of Somerset. And I believe that's a national disgrace. So the gross problem we've got is that people are dying when they shouldn't be dying. They're dying younger. And when they're living, most people who come from the most deprived areas have 2 or 3 more illnesses, comorbidities, before they're sort of 55, 60 than those in the richer areas. So almost all of the people in deprived areas are reaching retirement age with significant health problems. And so we've got to do something about that. But this talk is about a subset of that. So a lot of my work over the last 2 years has been chairing what's called the National Inclusion Health Board. So I've had the national responsibility for looking after or promoting the health of gypsies and travellers, sex workers, asylum seekers, vulnerable migrants, and the homeless. So most of this discussion is about the group which are at the bottom of Michael Marmot's gradient. And what I want to do is use those as an example of how we need to improve things. But I want to start with a piece of work we finished on Monday, which is about the NHS Constitution. So my third phase of the Future Forum work, working to the Prime Minister, has been to revamp the Constitution. And we're out at the moment for a public consultation. But the Constitution is the set of values which was approved under the Labour government and owned by all 3 governments, and is now out for consultation to be strengthened. And putting homelessness into the context of what our NHS is all about. And this is the paragraph which is in frosted sort of engraving on all of the walls of the new commissioning board. It's in the job description of everybody who's being appointed to the commissioning board and to Health Education England. And it's what those of you who work in the NHS will be finding more in, if you're applying for medical school in Manchester, they're starting to look at the values of the Constitution as part of the defining thing about the NHS. So, and we believe this is a very powerful paragraph which talks to us about the NHS. The NHS is there to improve our health and well-being, supporting us to keep mentally and physically well, to get better when we're ill, and when we cannot fully recover, to stay as well as we can to the end of our lives. And we think that sentence is really important, because whenever a health system is under financial pressure, it's the health of the poorest which suffers fastest, and it's the mental health of people which gets forgotten. And so we want to make some very strong points about the parity between health, physical health, and health, mental health. Works at the limits of science, bringing the highest levels of human knowledge and skill to save lives and improve health. So we're setting up as a commissioning board a series of academic health science centres because we want to get innovation and best quality care into the whole of the NHS as quickly as we can. But also in the Constitution, there are rights for patients so that they are entitled in law to have NICE approved drugs and treatments, which should cut out some of the postcode lottery that we've got. That's been in place now for 4 years, but still people are breaching that, and we want to make sure that if you live in Nottingham, you have the same opportunity for treatments as you would do in central London or in Carlisle or wherever you live in England. And then it touches our lives at the times of basic human need where care and compassion matter most. And coming from an area where, as postgraduate dean, one of the hospitals where I had trainees and medical students was Stafford, and having spent a lot of time talking to people in Stafford, the patients, the GPs and the consultants, something has gone badly wrong with our professional lives and how we look after patients for Stafford or Winterbourne View to happen. So there is something about where has all the care and compassion gone, because the evidence is that actually Stafford really wasn't exceptional. We think that Stafford came to light, but we found examples, and you'll know examples of individuals and units where the care isn't as good as it should be. And what we want as a commissioning board is to ensure you can have the same degree of care, compassion, be treated with dignity, again, whether you're in Leicester or Nottingham or Birmingham. And again, as we go around the country, we discover that homeless people, gypsies, travellers, asylum seekers, are frequently turned away from their GPs. They're treated in an inhumane way, in a humane way, in A&E when they go there, and treated as a nuisance. When really, if we could look after them and get them back on their feet and improve their health, working with housing and social care. In fact, as you'll see later, it not only is the human thing to do, but it also saves the NHS a fortune. And the NHS values are these: treating people with respect and dignity, striving to improve lives, quality of care, compassion, working together for patients, and everyone counts. And you'll see if you go onto the Department of Health or the Commissioning Board website, the Constitution, in its update, does a number of things, but one of them is to say that if you look after the staff well, they will automatically provide better care and compassion for their patients. And this is about helping people develop. So if you're a nurse, we heard that some nurses that we met hadn't had an opportunity to go on a course, CPD, for over 20 years. We hear when we meet with GPs and their staff that many practice nurses aren't allowed out onto courses. Some GPs haven't been on courses because they choose not to go on courses, so they're not keeping up to date. And we hear the same in hospital as well. Hospital doctors tend to do better because it's written into their contracts. But if we're not looking after staff, whether you're a porter or a consultant nephrologist, you're unlikely to treat patients with the dignity and compassion that they need. And in the business sector, that's the philosophy of John Lewis, who we've met with many times. They spend most of their time talking about happy staff, keeping staff content and valued, treating them with dignity, because they believe that they will treat their patients with that dignity as well. So the starting line of the Constitution is that the NHS belongs to the people. My contention is it doesn't really belong to you if you're homeless, unless you happen to live in an area where you've got a very good homeless setup, or the doctors and the nurses particularly care. Most homeless people we meet have been turned away from a surgery or have been treated as though they're a nuisance. So with some facts and figures, gypsies and travellers, which is one group we're looking after at a national level, but aren't being looked after locally, have a very poor health outcome. A lot of mental health issues, not helped by the stereotypes you see on Channel 4, which have been very unhelpful for a lot of the Irish travellers in particular. And they have a lot of anxiety, they're very depressed, and they die young. Asylum seekers as well. For those of you who look after a lot of asylum seekers, I do in my practice, many have been tortured psychologically and physically, but within a 10-minute consultation it's very difficult to elicit any of that. And sometimes it comes back as aggressive behaviour because they haven't learned how to work with health professionals, because their experience in their own countries is pretty poor. And sex workers find it very difficult as well. So about 1 in 4 sex workers are likely to be honest as prostitutes with their GPs about their occupation. And because they're not honest about it, because they feel they'll be judged, they don't share all the issues about being at risk, and they don't get into the psychological issues with post-traumatic stress disorder, particularly the same as those coming back from Iraq. So from a homeless point of view, Homeless Link are a charity which looks after lots of other charities. So it's the link between homeless charities, and they have lots of examples of what patients are saying to them about their healthcare. In many cities in this country are discharged straight onto the street rather than into a sheltered hostel or accommodation. And gypsies and travellers are the same, and sex workers are very, very similar. And I've got a letter here from a GP surgery dated the 6th of August 2012, and this was a letter from a surgery 200 yards away from a centre for rape and sexual abuse, a women's hostel, which I was privileged to go into as one of the few men that were allowed to go into there. And when I went in, I spoke to a number of prostitutes who were there, And the person looking after gave me this letter. And it says, it starts with, we currently have some of your residents registered at our surgery, and with great difficulty we've been managing their general health. Most of these patients reluctantly comply with our GPs and often turn up very late or miss appointments. Most of the new patients present themselves at surgery without any background information on their health or previous GP details, demand acute medications. We understand that these patients are from underprivileged, difficult and somewhat disturbed backgrounds, and they will have some social and mental health issues. However, after careful consideration, we've decided not to register any more of your residents due to poor compliance and non-attendance at appointments. And we've got lots of this information, but that surgery are breaching all of their sort of major contracts they have with anybody, and from a human rights point of view, it's disgraceful. They now do look after them, but for that sort of information from a surgery to a hostel, for women who've been raped and abused, I think it's disgraceful. And as a GP, it makes me very embarrassed. So homelessness, we haven't got a sensible estimate for how many homeless people there are in this country, but there is a definition. The reason we don't know how many people there are, it's because we have lots of people who sofa surf, who don't declare themselves as homeless. So this is the DCLG definition of homelessness. But it includes rough sleepers, which are tiny in number. And in London, there are very few rough sleepers now because there's a policy of seeking them out and helping them as soon as they're found on the streets. And in Birmingham and other places, this is coming in as well. But many live in hostels, bed and breakfast accommodation, sofa surfers. So we think there's somewhere between 40 and 100,000 in the country. There could be double that. In the city of Birmingham, where I'm a GP, we know that there are 1,000 young people between 14 and 24 who are in what you would call hostel accommodation or sheltered accommodation, led and run by St Basil's charity. And in London, we know there are 3,000 with Kids Company, with Camilla Batmangela. So, and that's just scratching the surface of young people. And when we talk to both of those charities, they say it's very, very difficult getting consistent general practice support for them. And this is a map of where people who are rough sleeping tend to be. And you'll see that the numbers have reduced, particularly there's a lot of them in London because people gravitate to London, but those numbers have reduced since the second night out policy has come in. So what we try to do is help people when they're identified the first night of rough sleeping in order to help them not have a second night. This data is the most recent we've got. It goes from 2004 to 2008, and you can see that the mix of people is changing, and we know anecdotally that the number of Polish homeless people has increased in line with that more and more over the last 2 to 3 years. And the Somali population is increasing as well. And in Birmingham, we see quite a few Somalis who are in difficulty. But because they come from different backgrounds, they also have different needs as well. And you'll see the Polish figure in the second one along there have major alcohol problems. Whereas when we start to look at other groups, they're very, very different. So the mental health issues come out amongst most, but alcohol with the Polish and Central Europeans. In the UK, we get a mixture of drugs and alcohol. So what we know from a number of surveys, most of these either come from Crisis or from Homeless Link, and this is something that I funded through the Inclusion Board for Homeless Link. 85% of homeless people say they're registered with a GP. That means 15% aren't. And when they're registered, they tend to move GPs, apart from in areas such as Oxford, where they have a central surgery for the homeless next to the courthouse in the centre of Oxford. And they're paid extra money on a new contract to get people off drugs, help them with their alcohol, support their mental health. And then when they're stabilised, they tend to move then to one of the existing GP surgeries. So it takes the load off the surgeries. And in London, there are a number of systems like this as well, and in Cambridge and elsewhere. But we know that compared with the rest of the population, homeless people spend a lot of time in hospital. They stay longer. They attend A&E around 8 times more than the rest of the population. And when we looked at a particular surgery in Cambridge, we found that the average age of death there was 44. In London, depending on the survey, it's either 40 years or 47. It's in your early 40s. That's when on average people die. When you go into a hostel, if you just ask a question, how many people have died in the last 6 months, there's always 1 or 2. And all of the deaths are treatable. But they're complex and they need a lot of support. The suicide rate is very high. The TB rate is very, very high. I think they have a 200 times increased incidence rate compared with the rest of the population if you're homeless, 200 times. And what we're finding is that is then spreading from them, and there's a lot of resistance TB in London. A study in Birmingham looked at our homeless population, we looked at the UK homeless population, and then the English average, and you'll see that their health behaviours are very different to the average population, and their mental health needs are much greater. And this all costs a lot of money as well. So what we know is if you intervene and help and treat people, if you treat their TB, we know that that prevents other people being infected, but it also saves the health service money. But if you provide housing and respite for the homeless people when they're admitted to hospital, we know that saves money as well. So our assertion is if you spend money now, you're likely to save money down the line. And for those of you involved in CCGs and health and wellbeing boards, we think this is an urgent issue which will help your population, but also save lives. And you can read the figures for yourself. It's a lot of money going into this. So what are we doing about it? Well, we have an inclusion board which I chair with the minister who's just changed. So Anna Soubry is the minister who comes to all of the meetings. Michael Marmot is a member of the board, and we have people on the board who represent voluntary sector and epidemiology and GPs who are doing work, and I'll talk about some of their work in a minute. But what we've been trying to do over the last year is make sure that in the legislation and in all of the regulation, health inequalities and health inclusion is in there. So the Health and Social Care Act, for the first time, puts a statutory responsibility on the Secretary of State to address health inequalities. And next week or the week after, you'll see that the mandate, which is the instruction from the Secretary of State on all of us in here, the commissioning board and those delivering healthcare to deliver, includes in the first paragraph health inequalities as one of the major things that the commissioning board, the NHS, has to do. So we've tried to get it in all of the regulations, in all of the legal framework. So basically resistance is futile. When you're a CCG, your job is to look after the population in your CCG. You will be expected to make sure that you're looking after the homeless and the very deprived as a priority within your plans, which we'll talk about. So the Health and Social Care Act gives legal duties. The commissioning board has a legal duty. And all the way through, it's about provision of services, identifying the need and delivering. And where we are at the moment is that a lot of money is going in across government. So the coalition government is committed. In fact, they're doing more, strangely, than the government before was. From a cross-government committee point of view, there's a real focus on health inequalities and on inclusion health. And the Ministerial Working Group has been working with the CLG leading to try and make sure we maximise the benefit from the amount of money you can put from local government or from the health service. So there's £400 million going in over the next 4 years to tackle homelessness from a housing and a support point of view, and far more money going in, as you'll see there. And what we've done is, from an inclusion board, is launch some work. So we've got a pot of money we're funding for work. So we're funding the Royal College of GPs to look at how they as GPs can support, or we as GPs can support people who are very vulnerable and socially excluded. So they're doing some work on that for us. Homeless Link did a review of hospital admissions and discharge, and we've got others doing more work across the country. So what can we do about this? So in the new structures, we have a commissioning board that sits on top of basically everything. But what we want to do as a commissioning board is support the local CCGs. So this is going to be more in the future about the local NHS delivering for local people, and the commissioning board there to support them. And at a local level, you'll have a CCG led by clinicians, and they will work with local government and with housing and sport and education and local government and public health to identify the needs of the population through what's called the Joint Strategic Needs Assessment. And that will then help commissioning of new services. So in a town like Birmingham, where our homeless services are not sufficient at the moment, we would expect the CCGs to commission new forms of primary care in order to deliver better care. And that will cost more money. It will mean that it will need dedicated substance misuse support, mental health support, in order to target homelessness and the very vulnerable. We would expect the CCG also to start working with faith groups, with people from the different cultural groups we've got across the city, in order to address their needs from a health inequalities point of view. So we'd expect a lot of work going on with the mosques and with the temples, because that's one way of getting to put the population which don't come forward to us in healthcare. We can talk about that if you want the questions. But the local health and wellbeing boards are the group that brings everything together. So their job is to identify the need. The commissioner's job is to commission services locally. And our job at the centre is to support them to do that and point out good models, or if they're not going far enough, to help them with that. The JSNAs, and this reminds me of Cambridge, where that GP surgery was, will identify what the need is. The commissioners will then commission, and each year the annual report will look at how well they've delivered on that. The other thing that will happen is, because the GP contract is held centrally, the local area team in the new system will make sure that the GPs are delivering the care for the whole population. The CCG has a responsibility for the quality of care locally, so the two groups will need to work together. So for Nottingham, the focus is going to be really on the city and outside. We want to remove the barriers to registering homeless people. When I was at a similar meeting in Oxford, the GPs there were offended by the fact I asserted that they weren't signing on homeless people. And they showed me a document from the fraud service, the guidance to GP practices on GP registration fraud. And what we did with that, which is basically saying to GPs, don't register people until you've got 2 pieces of information proving they live and exist and they're entitled to NHS care. That document hadn't been approved through any of the equality mechanisms, and we had that withdrawn. So if we hear there are problems from patients and from GPs, we're happy to act and support them to prevent it. And this is just a picture of Richard Hobbs for Mike Pringle's benefit. We need to improve the access, and we want to encourage integrated commissioning as well as delivery. So the model for us would be the CCG would free up some money, the local government would free up some money, and they would commission together through the Health and Wellbeing Board. So you're using money from housing, you're using money from health, you're using money from education and schools, whichever you want, in order to provide better services. And if you start with inclusion, the poorest of the poor, we think you'll get quick wins. And then if you start to look out at the population across the city as a whole, you'll start to see how you can invest money in order to narrow the inequality gap very quickly. And we've had people look at the medical evidence for the inequality gap, and we've narrowed it down to things like 1.3% of the gap will be narrowed if you provide statins to that particular part of the population who don't come forward to GPs who are at high risk. If you're looking at the Punjabi population or the Bangladeshi population, we know they're having their heart attacks in the late 40s. We need to do more work with them right from birth and also helping them with their cardiovascular risk factors. But it's not just about primary care. We know that there are fantastic examples in secondary care. Often, secondary care comes to the table and delivers when the GP side of things isn't delivering. But we have an example which I want to talk about called the Pathway, which not only provides brilliant care, but also is led by a GP in a hospital. There are a series of really good interventions which we know both improve the patient's experience and their outcomes, as well as saving money in various parts of the country. But I want to talk about the London Pathway. Nigel Hewitt is a GP who lives in Leicester and used to run the homeless service for Leicester City. He was invited by an obstetrician called Aidan Halligan, who used to be the Deputy Chief Medical Officer, to set up at University College Hospital, London, a system called the London Pathway for homeless patients. And what happens there is that Nigel is in London for 4 days a week. He works in parity with the hospital consultants, partly to teach and support them, partly because he's a generalist and understands how to manage risk. When a homeless person hits A&E, automatically a coordinator is involved, and they work with them on housing, on benefits, and on health. And Nigel coordinates this service called the London Pathway. And part of our strategy for the Commissioning Board will be to roll this out across the country. Not only does it do that, but it trains up homeless people to be navigators for other homeless people. So we're getting people into employment through this. And a lot of the problems with homeless people is that they live chaotic lives, and just getting back into going into work and working with other people is a way of getting them into activity and into paid employment. And there are a number of these people who've gone through that. And over the last 2 years, the average length of stay has reduced. The number of bed days has reduced. And this is a conservative estimate that they're saving at least £100,000 a year in that hospital, and keeping people out of hospital, and getting people back on their feet. And we know their health outcomes have improved. So admittedly, the number of homeless who are involved going through the A&E department at UCLH will be greater than in cities outside London. But we believe a scaled-down version of this will help the care of the homeless. It will get them back on their feet, working with housing, reduces the number of A&E dependent attendances, and also helps them because they're allocated a GP practice, and it's a very different way of looking after people. Finally, other things that we need to do, this is about working with the third sector. This group, Groundswell, have got a fantastic scheme of getting homeless people to become mentors for other homeless people as they start to get into a more settled life and into jobs. And they've done some academic research where they've been training homeless people in research techniques, qualitative research, in order to get more evidence, in order to bid for more money and to get more services. And it's quite an intriguing way of doing things. In St Mungo's in London, they've got a system called Bricks and Mortar, where they take the homeless people from their hostels and they help them develop a skill, and that's bricklaying and plastering. And at the same time, they help them with substance misuse. their success rate is greater than the substance misuse services from the mental health providers, because they're usefully doing something, getting back into a routine at the same time as getting off their drugs. And these are people we're meeting there, which include doctors, homeless people who are doctors, people who've managed and led large companies. They're not just the people who've come from more deprived backgrounds. You're only a few weeks away from homelessness if something happens to you mentally and you don't get the support, and suddenly you can't pay your mortgage, and you suddenly then hit the drugs or the alcohol. We're all vulnerable. And it's only when you go and spend more time with these people you realise how vulnerable they are. And this person in the Pringle sweatshirt is a homeless person, and she's been working as a navigator for this pathway for the last year. And if you talk to her, she would tell you that she's now feels valued, she has a role, she's supporting other people to get well, and she's ready to now move on to the next stage. So it's about valuing human beings. And as Gandhi said, we must become the change we want to see in the world. So as GPs, as hospital doctors, as nurses, I believe we have a responsibility for the population around us. As an NHS, I think we have a responsibility as well, and we're meeting already to talk about how the NHS can provide more apprenticeships to get people into jobs, how we can use surgery buildings and hospitals for the community more, so they become more embedded into the local communities. Because if we could start to engage everybody in a much more fruitful way, perhaps we'll be able to help everybody address these inequalities. I'm going to stop now, because that's enough on homelessness, and just open any questions or challenges from you at this point. And those at the back.